Got it. Got it. Check the audio for the live stream.
Are we good? You good, guys? Hello? Hear me? All right. Guys ready? Cool. So welcome to your revision lectures. We're going to be starting off with neurophys and muscle physiology. I'm Steven, for you guys that don't know me. There's my email up there if you have any questions after the lecture's over. If you got any questions during lecture, just shout out. Got chocolate if you got good questions. But yeah, we'll get straight into it. So just a quick summary, we'll be talking about the divisions of the nervous system. So quickly going over the central nervous system, some of the stuff that does the peripheral nervous system and into the autonomic nervous system, which is kind of the more complicated stuff you guys have been covering this year. Then go into a bit of sensory physiology, so talking about receptors in your skin, a couple of pathways, and a little bit about central sensitization with pain and stuff like that. And then finally, a little bit of muscle physiology. Cool. So divisions of the nervous system. So I think it's pretty important that you guys get a good grasp of this stuff because it gives you a bit of context for everything else that we're talking about. If you don't understand this, everything else kind of doesn't make much sense. But we start off with the nervous system being split into two different things, the central nervous system and the peripheral nervous system. Our central nervous system is composed of the brain and the spinal cord. And the peripheral nervous system is split into motor and sensory, and then the motor part is into the somatic and autonomic nervous system. We'll talk a bit more about that later. So your central nervous system is made of your brain and your spinal cord, and I like to think of it as having pretty much three main functions. It receives sensory information from your peripheries, it processes that information, and then it initiates motor signals out to the rest of your body. Your brain does most of those initiation of motor signals, but you've got the one exception of spinal reflexes, where that whole pathway occurs within the spinal cord and doesn't ascend up to the brain. Motor systems, so you guys had Fashad, I'm sure you love that lecture. Yeah, it didn't make too much sense to me either, but I think he just made something that's not that complicated, very complicated. Pretty much what he was talking about was pretty much the motor pathway from the brain down to your muscles. So I'll give you a bit of an intro to the brain. It's probably good to have a bit of a general understanding of the brain. It's divided into two hemispheres. It's got 4 lobes in each hemisphere, the frontal, parietal, occipital, temporal. FPOT is an acronym that helps me remember that. Don't need to know this, it just kind of helps. And then the surface of the brain is what we call the cerebral cortex, and that's where all your neurons are, all the cell bodies for your neurons are. One of the regions in this cerebral cortex is that little bit up there in red called your primary motor cortex, and this is responsible for initiating all the motor signals that initiate voluntary movement. Cool. Bit of an aside, these are just some general terms and concepts that we'll be talking about, and you should kind of be familiar with. We'll do you in good stead for next year if you guys know what these things mean. So a ganglion literally means a collection of cell bodies outside of the central nervous system. And when I say cell bodies, I'm talking about this thing over here. Nuclei is exactly the same thing as a ganglion, except it's within the central nervous system. And a tract, when I talk about your pain tracts and your sensory tracts, I'm just talking about a collection of these axons that go up and down the spinal cord. So yeah, those are just some simple terms to be aware of. Cool. So motor systems. This is pretty much just a summary of what we call the corticospinal tract. So if you guys are ever confused going over Fashad's lecture notes, just look up corticospinal tract and it'll make a bit more sense. But what you've got pretty much is a neuron that starts up in your motor cortex and it ascends down your spinal cord and then synapses at the ventral horn of your spinal cord. I'll get a bit more into the details of your spinal cord in a second. But you pretty much have this one neuron that comes all the way up from the brain to your spinal cord at the spinal level that's going to exit and then synapse and leaves as part of the spinal nerve. One special thing to notice with all the tracts is that they cross over. So all the motor control in our body and all the sensory control in our body is contralateral, which means movement of a right hand is controlled by a left brain and sensors that you detect in your left hand goes to the right hand side of your brain. So it crosses over at a certain point, and it's helpful to know where that crosses over. And the corticospinal tract crosses over at what we call the medulla. So medulla is just part of your brainstem, right? And yeah, we'll talk a bit more about other pathways that cross over at different points, and it's good to know where they cross over, especially next year. Cool. And this is that just summed up. You've got your neurons starting off up in the top at your primary motor cortex. It sends down, and then that third slice down, you can see, fourth slice down, you can see it crosses over at the medulla. It decussates. That's the word we use, and it goes down and synapses at the ventral horn and leaves as part of the spinal. Bit of a mistake on that picture. That's not supposed to be the left-hand side of the brain up there in the top left. It's the right-hand side, because like left hand, contralateral organization, that kind of jazz. This was a picture that was in Fashad's lecture. I don't know. Yeah, don't worry about it. It's just kind of talking about how there's a complex interaction between different systems in your brain. You don't really need to know any of that. Just know that the basal ganglia and cerebellum are also involved in motor control of your body. We'll talk a bit more about those two a bit later on, but really, yeah, don't waste your time. So primary motor cortex and primary somatosensory cortex. So as I said before, these are just regions of your brain, the cortex, the surface of your brain, that are involved in the motor cortex initiating motor signals and the sensory cortex receiving sensory information. Again, it's contralaterally organized. And one cool thing about these is the proportion of cortical space devoted to any part of your body represents in the primary motor cortex how much dexterity you have. So your hands are going to have a lot more cortical space dedicated to them as opposed to, say, your knees. And in the primary somatosensory cortex, the proportion of cortical space is proportional to how sensitive it is. So in this diagram, you can see that the tongue probably has more space dedicated to it than, say, the knee. And I think that's the example one of your lecturers might have used about his son that got a massive gash on his knee, as opposed to cutting your tongue, which hurts a lot more. And this whole organization of changing the proportion of cortical space representative of each part of the body is what we call a homunculus. And that's this beautiful man over here. So this one over here is your motor cortex, your motor homunculus, sorry, and this is your sensory homunculus. They're just nice to look at, I guess. Cool, your cerebellum. As I said before, this is involved in coordinating a lot of your movements, and it's involved in balance. And those are the two things you really need to know about it. Just that if you do have damage to this, you can have problems with balance and coordination of movements. And you guys know that from your upper limb neuro examinations, from your coordination tests, testing for cerebellar lesions, and also testing for gait and stuff like that. It also is involved in motor learning, so learning implicit memories, and also cognitive functions, so like learning language, and I assume that's to do with things like articulating speech. Basal ganglia is the other thing that's kind of involved in regulating your physical movement, your voluntary movement. Don't need to know too much about it, you'll go on to it next year. It's just if you have problems with this, you have problems with some of your movement. So it does a few things. It's involved in planning movement, supports movements that are done subconsciously, the timing of movements and how large these movements are. Don't really need to know that in any detail. You'll cover it when you guys talk about Parkinson's and Huntington's disease next year, which are when we have problems with the basal ganglia. Cool. Spinal cord. The spinal cord has 3 functions. It pretty much carries information up to the brain, sensory information or afferent information, and we like to call that the ascending pathway. It's a bit intuitive to think of it as signals going up to the brain. And then it also carries motor signals down from the brain to the rest of the body, and we call those efferent or motor signals, and we call that the descending pathway. Its third function is what I kind of talked about briefly before, the spinal reflex, and this is the only exception where you don't have a signal being initiated in the brain. The signal comes in, synapses directly within the spinal cord, and then leaves to the effector organ. So here's a spinal cord. It's good to be familiar with the spinal cord. So you've got your white matter kind of surrounding there, and when I say white matter, all I'm talking about is the axons of those cells that we're talking, that the picture that I showed you before, just the axons. And you've got grey matter in the middle in this butterfly shape, which are the cell bodies, again, and that's why they're called grey matter. And what you have is all the sensory nerves originate in your dorsal horn of your grey matter, and they lead through the dorsal root of your spinal cord. And your ventral, your motor nerves originate in your ventral horn and lead through the ventral root. And that's important to know because if you guys have kind of talked about this before, but if you have a lesion in your ventral root or your dorsal root, you're only going to affect one of those, whereas if it's your spinal nerve, you can affect both of those things. Your dorsal root also has this ganglion over here. So whereas you have the cell body over here for the motor neuron, that cell body is located outside of the central nervous system over there. And we see something similar when you look at the autonomic nervous system later on, but there's a bit of a distinction there, and I'll cover that in a second. And yeah, the dorsal root ganglion, that's where we see shingles kind of affecting us. So yeah, good to keep that in mind. And this acronym always helps if you forget where things are. So same Dave, so sensory is the same as afferent, motor is the same as efferent. Dave, dorsal is the same, dorsal is sensory, so dorsal is afferent, and ventral is efferent, ventral is motor. Making sense, guys? All right, spinal reflexes, they occur without input from the brain. We've got two types of reflexes, monosynaptic and polysynaptic reflexes. Not that important to know the difference between them. The only thing is monosynaptic reflexes have one synapse, so they're going to be faster. Polysynaptic reflexes have more than one, so they're a little bit slower. This is an example of a monosynaptic reflex, a stretch reflex, so what you guys are testing in your upper limb examinations. What you have there is you have these spindle receptors, muscle spindles, which are stretch receptors in your muscles. When they get extended, it sends this signal back through that dorsal, through that sensory neuron into the dorsal root ganglion. And then that synapses directly with this motor neuron in the ventral root. And then that ventral root goes ahead and contracts your muscle and causes contraction. Another thing you have going on at the same time, which is just to note, not that important, is that when this goes back, it also synapses onto a inhibitory interneuron, remembering that we have two types of neurotransmitters, excitatory neurotransmitters that increase the likelihood of neurons firing, and inhibitory neurotransmitters that decrease the likelihood of neurons firing. So if we're activating this inhibitory interneuron, we're going to be inhibiting the neuron that comes off that later on. So then we go ahead and inhibit that antagonist muscle, so your triceps and that biceps reflex, and that allows for smooth contraction of that muscle without inhibition from muscle tone in that triceps muscle. Cool, just to note, and that's technically a polysynaptic reflex because you've got an interneuron in between those. And the picture on the right is just that in a bit more detail. Polysynaptic reflex, so this is an example of withdrawal reflex. It's exactly the same thing. You have sensory information from nociceptors in your skin. It heads up to the sensory neuron through the dorsal root, synapses with an interneuron this time, which then synapses to the cell body of an efferent neuron in the ventral horn, exits the spinal nerve, goes to the muscle and causes withdrawal. The Golgi tendon reflex is a cool one, not as examined as the other ones, I don't think. And all this does is ensures that no single muscle fiber or motor units, I'll talk a bit about that later on, is under too much tension when your muscles are contracting. So what happens is it notices how much stretch and the rate of stretch there is in some of your motor units. And if it's too much, then it inhibits the amount of stretch in those ones and increases the amount of stretch in other motor units in the rest of your muscle. And that ensures that force is kind of spread out evenly and it stops you from tearing your muscles and avulsion, which is when the muscle kind of rips off the bone. Cool, done with the central nervous system, easy. Peripheral nervous system, it's split into sensory and motor, or that's the way we like to split it. Sometimes you might see it split into directly into somatic and autonomic, and then they say that somatic has a sensory and a motor component to it, and autonomic has a sensory and autonomic component to and motor component to it. I think this one's a bit easier to understand. The other one, the only reason people say that is sometimes sensory nerves travel with your autonomics, but yeah, it's not. Don't stress too much about it. But yeah, we'll talk a little bit about the autonomic nervous system to start off with. So the autonomic nervous system, you guys are familiar with the sympathetic nervous system and the parasympathetic nervous system. Your sympathetic nervous system is your fight or flight. Increased levels of physiological arousal gets you ready to for physical activity. But the reason we define it as a sympathetic nervous system isn't solely on its function. It's to do with where it is and where it originates from. And so there's an anatomical basis to this division, and it's important that you know that next year, especially when it gets a little bit more complicated. So the sympathetic nervous system is defined as spinal nerves that carry autonomics that originate from T1 to L2, or have a thoracolumbar distribution, and then the parasympathetic nervous system, para meaning either side, is either side of that. So you have a craniosacral division. Craniosacral distribution of those nerves. You also have the enteric nervous system, which is the gut brain, but you guys will have plenty of fun with that next year. This is a quick summary of all the things that the autonomic nervous system does, what the sympathetic nervous system does, what the parasympathetic nervous system does. It's pretty intuitive. Sympathetic nervous system, we're going to increase things that you need when you're kind of running or doing exercise. It pretty much everything just goes up except for your digestive processes, and then with the parasympathetic nervous system, everything goes down except the digestive processes. But yeah. Cool. So here we can see the difference between our somatic nervous system, which is one neuron from the ventral horn out to the skeletal muscle, and the autonomic nervous system, where you have one preganglionic fiber that comes from the grey matter. It synapses at a ganglion, which is a collection of cell bodies outside of the nervous system. And then we have a postganglionic neuron that lives after that. And so that's the real distinction between this stuff and your motor and sensory pathways. It's that there's two different neurons in your peripheral nervous system. Another thing to note is kind of the length of the sympathetic and parasympathetic preganglionic fiber. So in your sympathetic nervous system, you've got a short preganglionic neuron and then a long postganglionic neuron. That kind of makes sense when you guys look at anatomy. You've seen the paravertebral ganglion, so the sympathetic ganglion. They're right next to the vertebra. So sympathetic nerves, the spinal nerves are leaving, they're synapsing straight away. And then you've got the long sympathetic fibers. Whereas it's a little bit different with your parasympathetic nerves that you guys have kind of seen with your vagus nerve as well. So you guys familiar with the vagus nerve? It's a really long nerve and it gets close to your effector organ and then it synapses there. Yes. Cool. So a little bit more about your parasympathetic nervous system. Talked a little bit about this already. You've got a bunch of, so it's a craniosacral distribution, a bunch of cranial nerves that have parasympathetics with them. Don't need to know any of them yet, except for the vagus nerve, which you guys have talked about with your heart and lungs, maybe, yes. And you've also got sacral nerves that carry parasympathetics. So preganglionic neurons arise from nuclei up in the brain. Which are just ganglion, except within the central nervous system, remember? And yeah, that's what I've got written down there. Cool. This is the sympathetic nervous system anatomy down in words. I think it's better if I just kind of run through a picture with you guys. So this is a cross-section of a spinal cord with the spinal nerve leading out of it. If you get this picture, and you probably could, I reckon you guys can get your head around this picture, then you're doing really well in terms of understanding the peripheral nervous system. So all you've got is what we've talked about before. You've got that spinal cord, a cross-section of it with the grey matter in the middle and the white matter outside. You've got a dorsal root and a ventral root. We've talked about the sensory nerves kind of that lead through the back through the dorsal root and become part of the spinal nerve, and also talked about those efferent nerves a little bit. Your sympathetics kind of originate off to the side over there, in this area over here. Then motor, so they're kind of ventral, but they're a bit different, so that's kind of the venterolateral horn of the spinal cord. They leave like the motor nerves through that ventral horn, the ventral root, sorry. They become part of the spinal nerve, but what you see then is they leave again through what we call the white ramus communicans, and they synapse here in your sympathetic ganglion. So again, in anatomy, you guys, when you've done your dissections on things like the azygos vein and stuff like that, you can see the sympathetic trunk alongside the vertebra, and there's little kind of collections of cell bodies. So they're synapsing over there, and then they're leaving again through this grey ramus communicans to become part of the spinal nerve again. So that's where you have that intersection between this preganglionic neuron and this postganglionic neuron. So white ramus communicans, grey ramus communicans, the way I remember it is grey goes away. So that's when you have that postganglionic neuron leading. This becomes really cool because, as we talked about, the sympathetic nervous system is from T1 to L2, but we kind of need sympathetics to the rest of our body as well, not just that area. So we need sympathetics up to like our eyes for pupil dilation and sweating and that kind of stuff. So once this preganglionic nerve gets into the sympathetic ganglion, it can actually ascend or descend before it synapses. And so I don't know if you guys have noticed, but your sympathetic trunk is actually longer than where the sympathetic nerves originate from. So it can ascend up to a cervical level and then supply sympathetics up to your brain, or it can descend down to a sacral level and provide sympathetics to your lower limbs and that kind of stuff. Does that kind of make sense, guys? Yeah. Cool. Organization and neurotransmitters. So this is all we've talked about before. We're just adding in the neurotransmitters, which becomes important when we talk about pharmacology and that kind of stuff. So somatic nervous system, it's the simple one. It's just got the one nerve that starts off in the ventral horn, and it leaves out to your effector organ and releases acetylcholine and acts on the neuromuscular junction. Really simple compared to the other ones. We then got the parasympathetic nervous system, skip down to here, where you've got this preganglionic neuron, the really long one, and then it has this first intersection over here, which is a cholinergic intersection, which means the neurotransmitter is acetylcholine, and then the receptors are nicotinic receptors. So if you guys remember the two different types of receptors for acetylcholine, nicotinic and muscarinic receptors. If you're not too sure, that sounds a bit not familiar, have a look back at them because it's a little bit important. But you have nicotinic receptors at this preganglionic and postganglionic intersection. Then you have the short postganglionic neuron, and there you have acetylcholine again. So this whole pathway is a cholinergic pathway, but you have slightly different neurotransmitters, receptors on those affected organs. You have muscarinic receptors, which still respond to acetylcholine, but they act a little bit differently. And so that then acts as a different target for us pharmacologically. We'll look at that later. So yeah, sympathetic nervous system, very similar to your parasympathetic nervous system, except we've got the short neuron that leads straight from the spinal cord. No, sorry. This one leads from the spinal cord. Synapses straight at your paravertebral ganglion or the sympathetic ganglion, and we have a long one to the effector organ. And this neurotransmitter over here is again acetylcholine, again nicotinic receptors. So exactly the same as the intersection over here. But at the target tissue, instead of having acetylcholine again, we have adrenaline and noradrenaline. So that's an adrenergic synapse, and the receptors we have there are adrenergic receptors. So beta-1, so like alpha and beta receptors, which I'll talk about in a second. The one kind of odd one out in all of this is for your sympathetic division, you've got sympathetics that go to your adrenal glands. And then what happens there is instead of having a postganglionic neuron, your adrenal glands are kind of a link between your nervous system and your endocrine system. So the sympathetics innervate that, and then that directly releases, again, adrenaline as opposed to noradrenaline as a neurotransmitter, but it releases that into the bloodstream. And so you have systemic effects. Cool. And this is all that summarized once again, just knowing that here you have nicotinic receptors. Here you have adrenergic receptors, and here you have muscarinic receptors. And the reason, and these are your muscarinic receptors, so M1 to 5, and your adrenergic receptors, alpha 1, alpha 2, beta 1, 2, and 3. I'll go in a bit of detail with those in a second. Sorry. And the reason this all becomes important is because it means that we can have selectivity when we target them with drugs. So if you have drugs that are agonists for muscarinic receptors, you're going to have activation of your parasympathetic nervous system. If you have drugs that target adrenergic receptors, you're going to have sympathetic effects or sympathomimetic effects. And if you have antagonists for this, you have parasympatholytic and sympatholytic effects respectively as well. Does that kind of make sense, that step there? Yeah, cool. So here are your muscarinic receptors. I'll go through all of them really briefly. I'm pretty sure your pharmacology lecture will go through them as well. So quickly, your muscarinic receptors are M1, which are to do with gastric secretions, and they also increase seizure activity, not that important. M2, kind of important, so they decrease cardiac contraction and contractility. And M3, which is for smooth muscle. So causes bronchoconstriction, because when you're kind of running, you're not running as much, you need less air, and also vasodilation. It's also responsible for like sweat and stuff like that. M4 and 5, not important. They have stuff to do up in the brain. Not that significant. We don't really know how they work, to be honest. Adrenergic receptors, alpha 1. So they are in your vascular smooth muscle. They cause vasoconstriction, and they also cause pupil dilation with the eyes. So eyes and vessels for alpha 1. And just note that it causes vasoconstriction over here. Alpha 2 are weird as ones. They're on the presynaptic neuron, at the end of the presynaptic neuron, and they actually act as a bit of negative feedback. So if you have your presynaptic neuron releasing adrenaline out, it's going to activate itself, and then that's going to decrease the amount of adrenaline that neuron's releasing. So if you have drugs targeting this, you actually have a decrease in sympathetic effects. So that's the odd one out of all the receptors we kind of talked about. Beta receptors, we've talked about beta 1 receptors in the heart, important, increased rate and contractility. There's a bunch of other stuff, not that relevant to you guys now. Beta 2 causes vasodilation. And if we remember at the past slide, alpha 1 causes vasoconstriction. And what this allows is for activation of our sympathetic nervous system to have different effects in different parts of the body. So when our sympathetic nervous system is activated, we actually have vasodilation near our hearts and our coronary vessels, and that increases the amount of blood supply that goes to there because you've got these beta 2 receptors on the vascular smooth muscle right near your heart. But peripherally, if you've ever seen someone that's been scared, they go really pale. And that's because they have peripherally vasoconstriction, because they have these alpha 1 receptors peripherally. And then beta 3, not that important, on fat, causes lipolysis and relaxation of smooth muscle. That's a really shit picture for you guys to have a look at. But if you guys want to, if you're able to draw that out, it's a really good summary for what you need to know for the autonomic nervous system. If you know what each of those receptors do and you know what each type of junction is, then you guys are doing really well. Another quick thing that I forgot to mention earlier is that that synapse between the pre-ganglionic and post-ganglionic neuron is the same in both of those. So if you have drugs that stimulate nicotinic receptors, what you see isn't activation of the sympathetic or parasympathetic every time. It's just whatever aspect of the nervous system is more dominant when you give them the drug, that just gets exacerbated. That's not too important. Cool. Neurotransmitters in the autonomic nervous system. We've talked about noradrenaline, acetylcholine. Another one is nitric oxide, which acts in your parasympathetic nervous system and is important for the male sexual response. It's a powerful vasodilator, and you've also got other things in there, which aren't that important. One thing to note is that the way neurotransmitters are released is, they're synthesized in that axon terminal of your preganglionic neuron. They're then packaged in vesicles and secreted out, and then they go across to the receptors. But then you also have things that break down neurotransmitters while they're in the synapse, and you have reuptake mechanisms. So those are all targets that you can have for pharmacologically. Cool. Cholinergic junction. We talked about most of this before. We know it's acetylcholine that's going across. We know they're going to cholinergic receptors, which are either nicotinic or muscarinic. An extra thing in here is we have this thing called acetylcholinesterase here. And we also have reuptake mechanisms, not as important, but acetylcholinesterase breaks down acetylcholine. So normally, this is normally in those junctions, that down-regulates the amount of acetylcholine that is there. So if we have inhibition of these acetylcholinesterases or anti-acetylcholinesterases, you actually have an increase in the amount of acetylcholine that's going on. And that becomes important with the neuromuscular junction. So you guys might have touched on myasthenia gravis before in the past. So what happens is there's an autoimmune destruction of these cholinergic receptors at the neuromuscular junction. To treat that, what we give them is a drug that blocks acetylcholinesterase. That means that you have more acetylcholine, and then the effects of the decreased amount of receptors are kind of counteracted. Noradrenergic receptor, we've talked about this again before. The special things to notice here are, again, that alpha-2 receptor is the weird one. It's on that preganglionic neuron, and it negatively feedbacks into that preganglionic neuron. You also have reuptake mechanisms, and once they're taken up, they have these enzymes called MAO-A, or MAO, okay, never mind, and COMT, which break down the adrenaline. And so if you block those, or you block alpha-2 receptors, you increase the amount of adrenergic activity. Nitric oxide, as I said before, is a potent relaxant. It's part of the parasympathetic nervous system. Powerful vasodilators. It's another one of the weird ones. It's not stored in vesicles when it's released. It's actually lipid soluble, so it's released straight through the cell membrane. And it has a huge role in the male sexual response, and that's through vasodilation of the penile artery, which leads to an erection. So the way it works is it causes an increase in cyclic GMP. Don't need to know that, but the reason that's relevant is because Viagra works by inhibiting the breakdown of cyclic GMP. So the overall effect of Viagra is it leads to more cyclic GMP, which leads to vasodilation. And that's how Viagra works. There you go, the more you know. Human male sexual response. So it's the only part of the body, or one of the odd parts of the body, where you have both sympathetic and parasympathetics working together. I mean, they always kind of work together, but yeah. And so the penile artery is the only artery with parasympathetic innervation, and it uses nitric oxide, as I said before, for vasodilation. And that's important for an erection, but also for ejaculation, you need sympathetic activity. Because the vas deferens and other tubes that you guys will learn about later need to rapidly contract for ejaculation to occur, and that requires, funny. And so that involves sympathetic nervous system, which use noradrenaline and ATP. And so diabetes is a major cause of impotence because of nerve degeneration and vascular degeneration, and you guys have talked a little bit about that with diabetes and stuff like that. Cool, questions? Where does the corticospinal tract decussate? So cross sides. I'm going to pick on someone. Oh, yeah. What do you reckon? But yeah, well done. Yeah, shit, sorry. Throw it to someone else. Heads. That was mean. The neurotransmitter between the presynaptic and postsynaptic neuron in the parasympathetic nervous system is... Who's got it? Someone said it, but who's got the elephant? You guys lose my elephant? Acetylcholine? Yeah, whoever said that. Yeah, there you go. Yeah, that was better. Someone find my elephant. All right, acetylcholine. So the neurotransmitter between the presynaptic and postsynaptic neuron in the sympathetic nervous system is? Bin? What is it? Pick someone. Huh? What? You say it. I can't hear you. Oh, this has gone to shit. Palmer, what do you reckon? Yeah, acetylcholine. Well done. Sorry. All right, the neurotransmitter between the postsynaptic neuron and the effector organ in the sympathetic nervous system is? Basil, what do you reckon? What do you reckon? Yeah, well done. People are dying. And there's a short answer question. So whoever answers this gets like 2 questions. Where's my elephant gone? That helps so much. All right, hush, guys. Hush. Guys. Huh? Well done. You get 2, whoever said that. Oh, yeah. Hey, you're the guy that looks like Jack Frost. Alright. Cool, done with questions. Alright, central nervous system. So central nervous system regulating the autonomic nervous system. So, as with all motor components, you're going to have an input from the central nervous system on how things happen. The difference with the somatic nervous system and the autonomic nervous system is that the somatic nervous system, we're aware of that and it's a voluntary response. Whereas with the autonomic nervous system, these are all involuntary things that happen. It's not too important that you know all of these. They'll become more relevant next year. But things like the thalamus, the hypothalamus, the cerebral cortex itself, and the brainstem regulate a lot of this. It can get really complicated. So all you really need to know is that there's sensory information that goes up to the brain via certain tracts. They then communicate with certain nuclei in the brainstem usually, which then can communicate with more stuff in the brain. But then you have centers in the brainstem that carry motor information down to your viscera. Not important that you know all the details. I think Parker went into that. Like, don't. Yeah, you don't need to know that kind of detail. But yeah, I think one example she did use that was kind of useful was your baroreceptor reflex. You guys all know this one, which you're not supposed to be doing. Yeah, hush. Yeah, so, I'm sorry. Okay. Yeah, so you got signals from your baroreceptors in your carotid arteries. When you put pressure on them, the stretch receptors, that carries information up to your brain via this solitary tract. It's just an example of a tract. So up that sensory tract, that then goes to what we call the nucleus tractus solitarius, or the NTS. And then from here, communicates with a bunch of things that you don't need to know. But that then starts a signal in the cardiovascular inhibitory center, which is in your brainstem. And that goes on and decreases your heart rate and your contractility, decreases your blood pressure, and you pass out. It can be really confusing, this kind of stuff. It's not that high yield, so having a general understanding of it is more than enough. I think you guys talked a little about vomiting in some of your active learning or something like that. It's important to know it's not due to just stomach contraction. It's regulated by the vomiting center in your brainstem, in the medulla. And it cycles through a bunch of steps, and it's often preceded by salivation to stop the acid that you're about to regurgitate up from damaging you, and also to lubricate that vomit from going out. The steps for this are also deep inhalation. Taking a deep breath, close the glottis, stop breathing because you don't want to aspirate any of that vomit when you're spewing it out. contraction of the diaphragm and abdominal muscles, which increase your abdominal, intra-abdominal pressure. That causes ejection of your gastric contents, and then you cycle through that. So fun. Continued, you've got different triggers for vomiting. You've got the cerebral cortex itself, so anticipatory emesis. So if you feel like you're going to vomit, that probably adds to it. Motion sickness is done through the vestibular center, so that's to do with balance and stuff like that. You've got peripheral receptors, which get affected when you ingest toxins, things like chemotherapy. That's why nausea is a really big problem with people that get chemotherapy. And then also the chemoreceptor trigger zone. So certain drugs are able to trigger vomiting. Yeah. And that's that, again, just in picture form. And talking about some of the drugs that you can, or receptors you can target to counteract nausea and vomiting. The diabetic peripheral neuropathy, we talked about this before a little bit. It's important because diabetes leads to vascular damage peripherally. And the reason that goes on to cause nerve damage is because of damage of, for example, the vasa nervosa, which is the blood vessel, which is the blood vessel supplying the sciatic nerve. And once it gets damaged, that leads to ischemia of the nerve, which can go on and cause peripheral neuropathy, which is a big problem because then you have decreased sensation in these regions. You're not able to pick up when you injure yourself. You're more likely to go on and have infections and get amputations and that kind of jazz. Cool. Sensory physiology. So sensation is a conscious or unconscious detection of stimuli. It's a little bit different to perception because perception is how we interpret this information. So that picture over there, you're all getting the same sensory information, you're all getting the same light coming off that picture, but the way you perceive it can change. You can either perceive it as a young lady that's facing the back or like an old woman that's looking off to the side. So yeah. You guys don't see the old lady? Like that's either an eye or an ear. Yeah? Yeah, you finally got it. All right. So, so an example of this sensation being, guys. So, for example, your baroreceptors, the sensory information that you perceive can be either consciously perceived or unconsciously perceived. This, for example, we consciously perceive information from our baroreceptors we don't consciously perceive. Cool, types of sensory receptors. So the type of neuron and the type of information that neuron conveys is based on the ending. So you've got free nerve endings, you've got different types of receptors, which I'll go into in a little bit. But yeah, you've got chemoreceptors, mechanoreceptors, thermoreceptors, nociceptors, which are for pain, and photoreceptors for light. And one thing to notice here, again, like I mentioned much earlier on, is the location of that cell body. It's off in the middle over there, which makes a bit more sense when you think about organization of sensory pathways. So this is just a comparison of what we've talked about so far. So you've got your somatic motor neuron, really simple, starts off in the ventral horn, goes out to your target organ. You've got your sensory, your autonomic neurons, where that preganglionic neuron starts off in synapses within the ganglion right outside the body, and then that goes off to all your targets. And then you've got your sensory neurons, where you've also got that ganglion. But the important thing to notice here is that there's no synapse at that ganglion. And this makes a bit more sense in that at this one you have the two different neurons, whereas up in the sensory one you only have one neuron. It's just the only reason you have the ganglion there is because it's kind of a weird cell where the cell has that body in the middle of it. So instead of having your cell body over here like you do with a somatic motor neuron, that body's just shifted over here, and that's why we have a ganglion over there. Cool. We like to talk about sensation in terms of order of neurons. So we have our first order neuron, which is this one. This is your first order neuron. It then goes into your spinal cord through the dorsal root into the dorsal horn, where it synapses with another neuron. That goes up to the thalamus, the structure in your brain. And then from the thalamus, we go to the cortex. So this is our second order neuron, and this is our third order neuron. And all your sensory pathways, regardless of what information it's carrying, has three orders of neurons. Right. I think your lectures like talking about stimuli as either distal or proximal stimuli. So distal stimuli is the environment itself, and proximal stimuli is how you interact with the environment. So distal stimuli would be the back of the electric theatre, for example, and the proximal stimuli for me would be the light that's reaching my retina from the back of the electric theatre. The way neurons work is they detect proximal stimuli and convert them into electrochemical signals, into action potentials. And we've got a bunch of sensors that you guys are all familiar with: vision, smell, taste, hearing, touch, and then the fancy ones like proprioception, balance, that kind of thing. Sensory receptors. So the receptors, the whole role is to convert what we encounter, or the proximal stimuli we encounter, into an action potential or an electrochemical signal. And this process is what we call transduction, the changing of, for example, pressure into an action potential. With this process of transduction, we're able to encode characteristics into the signals that go up to the brain. We're able to encode what modality it is. So is it vision? Is it taste? Is it hearing? And we do that because of which neurons are being fired, so which pathway is actually going up. So if it's your optic nerve, you're going to know that's vision, as opposed to if it's like a nerve from your ears that are going to indicate that it's hearing. Intensity, and that's through the frequency firing of the neuron, number of fibers firing, and also if a weak or a sensitive receptor is activated, we know that it's a weak stimuli. Whereas if you have activation of weak and less sensitive, of sensitive and less sensitive receptors, you know that it's probably a bit more of a strong stimuli. And also duration, which you talk about with phasic and tonic receptors. This stuff's not all that high yield. It's just stuff that you guys covered. Phasic and tonic receptors, the only real important thing to note here is that with tonic receptors, you get information about duration, because they're receptors that respond slowly to stimuli, but they stay activated the whole time that you encounter that stimuli. So this is things like pain receptors and also muscle spindles. So for example, if you poke someone with a tack, they're not going to get used to the pain. They're going to know the pain is there for however long it's there. Phasic receptors, they respond quickly to stimuli, but they adapt to the stimuli over time. So eventually they stop firing. And the example there is like going into a cold swimming pool. When you first start off, it's really cold and you want to get out of there. But once you're in there for a while, you get used to it. And so that's things like odor, temperature, and touch. Somatosensation is just touch, or how we talk about touch, and that's grouped into different things, into tactile somatosensation, proprioception, which is where your position of your limbs and stuff are in respect to space, temperature, pain, object shape, haptic perception, or stereogenesis, balance and body acceleration, which is vestibular perception. So spatial resolution is the idea of how sensitive a region of skin is, and it's directly proportional to how many neurons we have innervating that skin, that region of skin. And we measure this in our upper limb neuro exams and lower limb neuro exams with 2-point discrimination. And the idea there is that with more neurons right next to each other, you're able to discriminate 2 points when they're closer to each other. And the further away they have to be before you can distinguish 2 different points, the less sensitive that area is, because there's less neurons in that region. And this actually reflects on our homunculus. When you look at the beautiful guys we looked at earlier on, the amount of nerve endings that you have here in the skin directly correlate to how many nerves we have up in the brain. So an area that's more sensitive has more neurons here, has a smaller 2-point discrimination, and also has a larger area of cortical representation in the primary somatosensory cortex. Skin. So it's grouped into 2 different types of skin, the hairy skin and the non-hairy skin, or your glabrous skin. Lots of things on here. Hair follicles have hair receptors on them, which are mechanoreceptors. You have Pacinian corpuscles, which detect things like vibration and deep touch, and Ruffini corpuscles. You have non-hairy skin, which are on your palms and your soles. They have a thicker epidermis and no hair. They also have Pacinian corpuscles and Ruffini corpuscles, but they have Messiness corpuscles and Merkel's receptors as well. I'll go into a bit of detail with these. So for most skin, most of your receptors are in your dermis, so down there, deep in your skin. But you do have some free nerve endings up here in the epidermis. And free nerve endings are important because, as we'll talk about in a while, that's where all our nociceptors are located. They're located as free nerve endings, and they detect things like pain, heat, and cold. Your upper dermis also has Messiness corpuscles, and your lower dermis has the Pacinian corpuscles, which makes sense because they're for deep touch. These are those receptors kind of summarized really briefly. I don't think it's too important to know all the difference between all of these. I mean, if you guys want to go ahead and know the difference between Messiness corpuscles being fast adapting and Merkel's discs being slow adapting, go ahead and do that. But Pacini and corpuscles are for vibration. That's probably an important one to know. And Ruffini endings are for stretch. So it's how we detect stretch in our skin. But yeah, you guys can go over that in your own time. Proprioception is a really cool thing, and it requires a lot of information. And you guys probably went through a case where you looked at a man that had lost his proprioception in one of your lectures, I think. And yeah, it's pretty interesting. And the way we have proprioception is through 3 different things. I'll talk about 2 of them. Joint receptors aren't that important. Muscle spindles, which we talked about earlier, which give you the stretch of receptors, and Golgi tendons would tell you the tension of those receptors. So using those 2 bits of information, we're able to know where our limbs are in position in respect to space. Okay, now we're talking about some of the more important stuff. This stuff comes up next year, so getting your head around the basics of this is kind of important. So the dorsal column medial lemniscus, which is a lot of words, but it's literally just a pathway, is a pathway that carries proprioceptive information, vibration, and fine touch. It does this through the 3 order of neurons that we talked about before. You've got that sensory neuron that starts off here with the sensory receptor, goes into the dorsal horn with its cell body located outside of the dorsal root, outside of the spinal cord in the dorsal root ganglion. Remembering there's no synapse here. It's not like your sympathetic ganglion. It then synapses here with a 2nd order neuron, which then ascends and then crosses at the thalamus, not at the thalamus, at the medulla. It decussates at the medulla, and then that goes on to your 3rd order neuron up in the primary somatosensory cortex. So again, remembering that this one, like the corticospinal tract, decussates at the medulla. The spinothalamic tract is your other sensory pathway. So these are the 3 pathways that we kind of covered so far: the corticospinal tract, the dorsal column, which is for proprioception and deep touch, and the spinothalamic tract, which is for pain. So it's for pain and light touch or crude touch. So the way this one works is it's exactly the same. You've got that 1st order neuron that comes into the dorsal root, synapses at the dorsal horn, but instead of going up to the medulla before it decussates, it actually crosses over straight over at the spinal level. And then from here, it goes up and it goes to the thalamus, and then you have your 3rd order neuron that goes from there into the primary somatosensory cortex. And the reason this is important is, like you'll talk about next year, is if you have a lesion above where it crosses, you're going to have loss of pain or loss of motor function on the other side of the body. Whereas if the lesion occurs below where this is crossed over, it's going to be on the same side as the same side of the body as where that lesion has occurred. Not too important, but just knowing where they cross over is something to keep in mind, because that becomes relevant a bit later on. So nociception is the sensory process that leads to perceiving pain. We use the spinothalamic tract, as I just mentioned before. And it can be either useful or not useful. So you have physiological pain, which is important. It alerts us when we need to attend to something, and you have chronic pain, which can be detrimental. And that can be either inflammatory or neuropathic. So inflammatory can be something like arthritis, and neuropathic can be something like shingles. A couple of terms are hyperalgesia, which is an exaggerated response to noxious stimuli. And you've also got allodynia, which is a pain response to normally innocuous stimuli. Nociception occurs in 4 phases. The first one we've already talked about, transduction. So that's detection of stimuli by a receptor, and that converts that into an action potential, an electrochemical signal. Transmission is carrying this information from the central nervous to the central nervous system. And then we've got this interesting one that we'll discuss in a bit of detail, modulation, which is when you have signals that come from higher up, higher centers, that change how we perceive that information. So they're actually signals that come down from the brain and affect how much sensory information goes up from your sensory neurons. And finally, we have perception, which is when the individual becomes aware and conscious of pain. Nociception, so we've got, those are your different neurons that you kind of covered last year, not that important. So transduction, nociceptors, the neurons are free nerve endings, like I mentioned before, and this is where you get the conversion into an action potential. You then have transmission of pain, and you have 2 different types of neurons that can transmit pain. You have A delta fibers, which transmit fast pain, and those are these guys over here. And so that's fast pain. So when you're asking me history, so things like sharp pain, which are myelinated, they're well localized, so you're going to know where that pain is. Whereas C fibers are for slow, dull pain, which are unmyelinated, and they're poorly localized. So someone might say they have a dull ache over their abdomen or something like that. Those are 2 different types of pain. Transduction, cool, that's that again summarized. So again, associated with sharp, brief pain for A delta fibers, and then dull burning pain for C fibers, well localized and more diffuse pain. Quickly aside to kind of some of the stuff Sunny might have talked to you about last semester. Do you guys remember the gay theory of Cain? Kind of, maybe, no, okay. So all this is kind of talking about is you have these sensory neurons that are coming in from your peripheries, and what happens is if you, like, for example, if you jab someone with a needle, giving them an injection, and then after a while you rub over that area, what you do is you also stimulate this A beta fiber for deep touch, and that goes on and activates this inhibitory interneuron. And remember, if we're activating an inhibitory interneuron, that's going to have inhibitory effects on whatever neuron that acts on. So we activate this neuron, which then goes on and inhibits the second order neuron that's carrying nociceptive information up to the brain. Is that kind of making sense? So what would normally happen is without this rubbing over the area, you have sensory information that just goes from here to that second order neuron up to the thalamus. But with rubbing over this region, you have activation of this neuron, which activates an inhibitory interneuron, and that decreases how much information or pain information that goes up to the brain. The reason I'm telling you guys this is because that's the same principle by which modulation works. If we ignore this part over here, we've got that C delta fiber coming in, synapsing with that second order neuron in your dorsal horn. And that would normally go up and just carry information to your thalamus. But we've also got this interneuron over here, this inhibitory interneuron that's able to decrease how much of that signal gets up. And by stimulating that neuron, we're able to decrease the amount of information that goes up. And that's where nerves from higher centers kind of come down and stimulate that neuron to decrease how much pain we experience. Yeah, so this interneuron releases enkephalins, which you guys have kind of come across before, because that's the site of action for opioids. So opioids decrease pain by decreasing how much of this sensory information goes up by inhibiting some of that neurotransmission. Cool. Is that all kind of making sense to you guys? Anyone want me to go over that again? That's all that's summarized, just talking about where some of those drugs might act. So just noting that opioids act over there. More questions. What color is the first order nociceptive neuron? Where'd my elephant go? I want to pick someone. Basil, pick someone. Yeah. Red? Yes. And like bonus marks, where is its cell body and where does it first synapse? Sorry? I can't hear you, but I'm going to assume you're right. The dorsal root ganglion and the dorsal horn. I'm scared to do this. Alright, which order neuron is the neuron with its cell body and the dorsal horn? Pick someone, the one that just answered. Don't pick Basil. Okay, fine. Which one? What did you say? Yeah, second. Yeah, well done. Oh, you're good? Oh, cool. Okay, what type of sensory receptor is this blue one likely to be? Can you pick someone, the one that just answered? Can you pick someone? Yeah, well done. You want a chocolate? Okay. Would you like a caramel, a koala, or a Freddo? Okay, those ones go further than the Freddos. This one's a bit of a tricky one. Do you want to pick someone? What effect will activation of this blue receptor have? Well, what effect will it have? Is it C? No. It's actually D and E. So what happens is when you activate this, you activate the inhibitory interneuron, which then also inhibits the second order nociceptive neuron. Good effort. Do you want to pick someone? C? Yeah, well done. Bonus question. Basil, what's going on here? Actually, whoever can answer this, just shout it out and you get like one of each. Oh, everyone knows what's up. Ben. All right, and that's a quick summary of all that. Where does the tract carrying proprioception and vibration decussate? Medulla? Yeah, you guys all know what's up. Cool, and again, where all those drugs kind of act. All right, referred pain, guys, quiet. All right, so referred pain, the way we explain referred pain is through something we call convergence theory. So like we've talked about with these first order neurons, you have the same type of neuron, guys, same type of neuron on the skin, and also on underlying structure, so your viscera below. And what can happen is the skin on the top can converge on the same second order neuron as where the nerves from the viscera converge. And so what happens is when you get pain information from these underlying viscera, it goes to the same second order neuron, but your brain is more likely to perceive it as coming from the skin because that's where it's used to receiving pain from. Central sensitization is just pretty much becoming more sensitive to stimuli the more pain you experience. And that's the reduced threshold for the nociceptive neuron to fire, an increase in the receptive field size for that thing, and also alters firing patterns and recruits other inputs into the pathway. So something that normally doesn't cause pain might cause pain after a bit of central sensitization. And this happens with things like postherpetic neuralgia. Neuropathic and thalamic pain. Neuropathic pain just refers to pain from abnormal nervous system functioning. So postherpetic neuralgia is an example of that. And it can be central or peripheral in origin. Bless you. Thalamic pain can arise if there's a lesion in the thalamus, so something like a stroke. And this goes on to cause allodynia or spontaneous pain. And it can be unresponsive to normal analgesics. So sometimes people use anti-epileptics to treat these. Okay, nearly done, guys. Muscle physiology. The types of muscle, skeletal muscle, it's striated, it's activated by the somatic nervous system. The neuromuscular junction is the interaction between the nervous system and these muscles. Cardiac muscle, striated, pacemaker cells, autonomic regulation. I'm not going to talk too much about that. I'm sure the person that's giving you the cardiac physics lecture will go into that. And smooth muscle, I just haven't got much on that either. So neuromuscular junction, like we talked about before, is a cholinergic junction. This neuron from the somatic nervous system comes in, releases acetylcholine, which then activates the muscle to fire. At these junctions, you also have acetylcholinesterases, and like I said before, myasthenia gravis, which is a disease of the neuromuscular junction. You have autoimmune destruction of these receptors to acetylcholine, and so if we can inhibit these acetylcholinesterases, oh, those blue things over there, that leads to more acetylcholine activity. Skeletal muscle, so starting from big to small, it's a muscle that's wrapped in epimysium. Then you've got fascicles, which are a group of cells which are wrapped in your perimysium. And then you've got a muscle fiber, which is a cell. Muscle fiber is kind of a confusing term, but it's a myocyte, it's a cell. It's just multinucleated because lots of cells kind of fuse together. And that's wrapped in the endomysium. And then finally you have myofibrils, which are composed of your thick and thin filaments, and then a sarcomere, which is your smallest contractile unit. We'll go into that. So this is your muscle fiber. You've got this thing over here, which is your sarcomere. And that's from one Z disc to the other Z disc. And a sarcomere composes of your thick and thin filaments and then regions that are defined by where there's overlap between those thick and thin filaments. You also have T tubules within your myocyte, which extend down closer to your sarcoplasmic reticulum. And that's important because that transmits the action potential from the neuromuscular junction over here in your sarcolemma, which is the cell membrane. It's just a name for the cell membrane for your muscle fibers. it transmits the action potential from there through the T tubules into the sarcoplasmic reticulum. And then the sarcoplasmic reticulum is really important because that's where you have a release of calcium ions, and calcium is important in this. So your sarcomere is the smallest contractile unit. It's from one Z line to the next, like I said before. The Z line is just where you have an intersection of these thin filaments, there and there. And then you have the I band, which is this region over here where there's only thin filaments. Then you have the A band, which is darker. When you look at muscle, it's called striated because it's got dark and light and dark and light. And this is a light part, the I band, and this is the dark part, the A band, and that's because there's overlap of the actin and myosin filaments. You then have the H zone in the middle over here, where there's no actin filaments, and it can be a little bit lighter, but not as light as that. And then you've also got the M line, which is this line over here, which is right in the middle. So yeah, just what I was saying before, where thick and thin filaments overlap, that's the darkest region. So thick and thin filaments, actin. So the thin filament has actin, tropomyosin, and troponin on there. You guys have kind of covered this stuff and are familiar with it. So tropomyosin covers the binding site that myosin heads have for actin, and troponin holds that in place pretty much. Myosin. So what happens is when calcium comes and binds to troponin, that moves tropomyosin out the way, and those binding sites become available to be bound to. Myosin, you have a tail pointing towards the M line and a head that points towards the I band, and then the binding site for actin is on there. You also have this ATPase on there, which is important when you talk about cross-bridge cycling. So cross-bridge cycling is pretty much the cycle that we go through for muscle contraction. I've got it down here in the steps that are the same as the picture, but I like to talk about it a little bit differently. So I like to think of it as starting off in this rigor form, so this low energy form. So what we have here is there's no ATP. We have this myosin, and it's bound to the actin without energy in a low energy form in this rigor state. You then have ATP that binds to that. ATP binds to the myosin head, and then the myosin unbinds from the actin, and then it's hydrolyzed by that ATPase that was on that myosin head. This then puts it in that cocked position, in an activated ready position. And then what happens is you have the calcium release from that. So the neuromuscular junction causes a calcium release by a sarcoplasmic reticulum, and then that exposes the binding site for myosin on the actin filament by moving the tropomyosin out the way. And when that happens, the myosin head then binds to that binding site. That causes release of your inorganic phosphate, which causes your power stroke. And then once your power stroke is completed, the ADP is released and you're back to this rigor state. Cool. And this rigor state is called that because it's in a low energy form, but your muscles are stiff because the myosin and actin are bound together. And that's where we get rigor mortis from. And that's just continuation of that. So this is all of that kind of summed up. You've got the neuromuscular junction. It causes an action potential in your sarcolemma that gets transmitted down through the T tubules to the sarcoplasmic reticulum. We have a release of calcium. Calcium reveals the binding site for myosin and actin by binding to troponin, which moves tropomyosin out the way. Then that causes the power stroke, which brings these actin fibers over myosin fibers. This was a little bit, this was something else that your lecturers kind of talked about. It's just talking about the optimal length in terms of stretch of muscles. So not how far you're stretching them, but how stretched they are at a passive state in terms of how much force they're able to generate. And all it really is that the more overlap there is between the actin binding sites and myosin binding sites, the stronger that contraction is going to be. So if the muscle is stretched out too far at rest, there's not going to be as much overlap between those binding sites, and the force generated is going to be less. And if they're pushed together too much, then there's again going to be less overlap because you have some of these actin filaments at that M line where there's no actual myosin binding sites, and also maybe the myosin pushing into those Z discs over there. So yeah, you've got A, which is the optimal length, C, which is stretch, so greater than the optimal length, and then D, which is less than the optimal length. And this little shaded region is the only region that's actually possible in our bodies without them kind of like ripping out. Motor unit, so I mentioned this way back, but one motor unit is pretty much just the amount of muscle fibers that are activated by a single neuron. The reason this is important is because once one efferent neuron is fired, it leads to activation of a whole motor unit. You can't activate part of a motor unit. So we have larger motor units for things that require a lot more force and smaller motor units for things that require less force. So if we want to do something like lifting a heavy object, we're going to use more motor units and larger motor units. But for small or finer tasks, we're going to use smaller motor units. Questions? What is F? B? Yeah, well done. What is G? Yeah, it's actually C, but yeah. No. And what is J? A. Vin, what do you reckon J is? Huh? E. And what is I? What? It's not I, no. H, yeah. We're done. And special thanks to Basil, who actually gave me all your lecture content. I'll stick around for a little bit if anyone has questions or anything.
I want to make Oh god, what do I do? Can I move this? Oh god, what is this? What is it?
Is that a oh, that's for the
Can I move it? Can I? Wait, can I like? No, don't be fine.
I'm leaving. I'm gonna go revision.
You shit. Just watch him later like me. How did you?
Oh, then they weren't on yours. I think it was the best. No, best thing was exercise.
Wait, help me find. No, help me find. I can't get all this here. What did you? Oh, smart. Ah, that'll do it. Here it comes. Oh, you would. All right, guys. Probably should get started. So Stephen went 10 minutes into my lecture, so let's do this real fast. It's Epi anyway, so we want to get out of here. So today, yeah, I'm talking about Epi. I love that like 10 people left as soon as my slides went up. Yeah, I don't really like Epi either. The only reason I'm doing this is because my friend asked me to. So hands up if you actually like Epi. weird. So EPI did take up a significant portion of our exam last year. So despite how boring or dry it is to revise, it's definitely worth it. You don't have to know it in depth, just sort of know like the general concepts and definitions and things like that, which is what I'll be going through today. So this lecture will basically be a general overview of all of that stuff, as well as a couple of shit jokes and things like that. So what I'll be covering is all of this. And I also have chocolate for people who answer my questions, like Stephen. So the first question, hands up, first one to answer, I guess, just, yeah, what is it? B? So it's all of them, but yeah, right. Sorry. Yeah, so you don't actually have to know the definition of EPI. I just thought I'd make an easy question for you. So firstly, causation. Let's get stuck into it. So causation is when something alone or in combination with other factors produces a specific outcome. So sufficient means that any exposure to this factor will definitely cause the outcome, and necessary means that the outcome won't occur without the factor. So you can have causative factors that are sufficient, necessary, both, or none. So an example of a sufficient factor is, say, decapitation is sufficient for death, but not necessary. You can die in other ways. Necessary, exposure to Mycobacterium tuberculosis is necessary for the disease to occur, but it won't just happen if you're exposed to it. You also need like a poorer immune system. An example of none is cigarette smoking is neither necessary or sufficient for lung cancer. So you won't definitely get it if you smoke, and it's not the only way to get lung cancer. And both is a necessary and sufficient cause of Ebola is the Ebola virus. You can't get it without the virus, and you will get it if you're in contact with the virus. I'm also working on 2 slides at the same time, so tell me if I'm on the wrong one. So factors for causation. There are 7 factors needed for causation. So I'll just go through them. Temporal relationship. So was the exposure to the causative agent before the onset of the disease? Fairly straightforward. Plausibility. Does it make sense? Is it consistent with other knowledge that we know? Consistency. Do many studies give the same finding? Do lots of people have the same outcome? The next 3 are associated with correlation. So strength of association is what is the relative risk, which we'll go into later when we're talking about measuring disease. Dose response. Does removing the exposure remove the outcome? And nope, that's reversibility. Dose response is does increasing the exposure increase the result? And strength of study design we'll go into later, but is the study you've conducted reliable enough to establish causation? What level of evidence does it provide? With confounders, a confounder is when there is an apparent causational association between a factor and outcome despite no actual link, and it's an external factor that links both of them. So that's an example of a confounder. So say, for example, a study found that a large proportion of those who regularly drink coffee go on to develop lung cancer. Non-epidemiologists would assume that coffee causes lung cancer, but in this situation, smoking is a confounder. So maybe smokers are more likely to drink coffee regularly, and we also know that smoking is a risk factor for lung cancer, so it links the 2 and makes them look like they're connected. Does that sort of make sense? Silence? Yep. Is that what lecturers feel like? This isn't important. Good stuff. So I decided that this question was just way too long and too difficult, so I'm just going to go through the answer with you. The entire scenario is pretty bullshit, but so a recent year-long RCT involving 32,000 people who had previously reported feeling fatigued found that iron deficiency is a possible cause of fatigue. The study involved half of the participants taking daily iron supplements while the other half were given placebos. After a month, the people who were taking it, only 500 reported feeling fatigued, while those who took the placebos all reported feeling fatigued. The people conducting the study were sneaky, and halfway through the year, they replaced all the iron supplements with the placebos, so those who were in the supplement cohort originally or reported feeling fatigue again. So I've written the causational factors there. So RCT, that's your study design, 32,000 people, so it occurred in a lot of people, so that's consistent. The iron deficiency is a possible cause of fatigue. That's pretty plausible based on prior knowledge that iron is involved with hemoglobin and that carries oxygen around the body. The results are showing the strong association After a month is the temporal relationship, and replacing the iron supplements with placebos is the reversibility. So the only thing that is missing is the dose response, and they could have done that by maybe having further subgroups with different dosages of iron and seeing the effects of that. So that's just all the results. So like the fact that only 500 people taking the iron supplements felt fatigued, whereas in the other one, all of them did, right? So when you calculate odds ratios and relative risk and things like that, we'll go into that later, yeah. All right, measuring disease, shit joke of the day number 1. That's Staph aureus. Okay. All right. So got to go fast. Let's do this. Prevalence measures the frequency of existing cases in a population, and incidence measures the rate of new cases over a period of time. So prevalence is the number of cases over the total population. Incidence is the number of new cases divided by the number of disease-free individuals at the beginning of the time period. So here's a question. I've highlighted the important parts for you. Read it yourself. So anyone got an answer for prevalence before? What? 60%? I should check that. Yeah. Who said that? Oh God, I'm so sorry. These don't fly as well as the Mars bars, whatever he was giving. And prevalence after. Good work. Oh, sorry. And the incidence. So the incidence of individuals going to the NOT. I'm sorry, this situation's a bit bullshit, but yeah. Anybody? 20%. Who said that? You're wrong. 50%. Who said that? Yeah. Oh, I'm so sorry in advance. Oh God. So I'll just go through that one. So yeah, a common error, guys, would be to say that the incidence is the 10 new cases divided by the total amount of people, that's 50. But incidence is the new cases divided by the number of people who are disease-free. So that's 20. Okay, that makes sense? Cool. Risk, okay. So some of these are pretty similar and they're easy to get confused. So risk difference measures the difference between the rate of disease occurrence in those who are exposed to the risk factor and those who aren't. So in this example, there are 110 people who were exposed to a risk factor and 110 who weren't. 100 in the exposed group have the disease and 20 in the unexposed group. So the risk difference is just 100 minus 20, and that's 80. Yeah, cool. So the attributable fraction calculates the proportion of cases that occurred because of the exposure. So if we want to know what proportion of the 100 cases in the exposed group were caused by the exposure, we assume that 20 people in the exposed group would have gotten it anyway, right? Because that's what happened with the unexposed group. So then 80 out of the 100 cases were caused by the exposure. Does that make sense? So of that 100 people who got the disease when they're exposed, 80 of them occurred because they got the exposure. So we do 80 on 100, which is 4/5, and then you can times it by 100 to get a percentage of 80%. Population attributable fraction's a bit different. They love asking about this one. So it measures the proportion of disease in a whole population that can be attributed to the exposure, or the proportion of the outcome in a population that would have been prevented if the exposure wasn't there. So it's the same principle as the attributable fraction. So if 20 people who weren't exposed still got the disease, take 20 away from the total disease population, and that's how many people got the disease because of the exposure. So this one is 120 minus 20 on 120, and that gets 5 out of 6. Does that make sense? Cool. Relative risk is measuring how much more likely you are to get a disease if you are exposed. So 100 divided by 20 is 5. You're 5 times more likely if you're exposed. That one's pretty straightforward. Odds ratios measure how strongly the exposure is associated with the outcome. So A and D on the table, they favor the two factors being related because they're both occurring together or none at all. And B and C suggest that they aren't linked. So one occurs without the other. So therefore, the higher the odds ratio, the greater the association. And in this case, it's 9,000 divided by 200, which equals 45, which is a very strong association. Attack rate didn't really come up much last year, but it sort of makes sense on its own, so I won't go through that. So there's another question. If you're looking at the slides I uploaded, I changed some of the numbers around, so they're a bit wrong. So yeah, just look at this one. So relative risk. How do we do that? I should probably go back. Anybody? If no one answers, I'm going to have to pick on someone because I've got to go fast. Hugh. What's the answer, Hugh? What? What? All right, tell me what numbers you're dividing or plussing. Okay, I can't hear you, so I'm just going to pick on someone else. You're right at the front, Karen. 400 divided by 150? Yeah, good work. Is that what you said, Hugh? Okay. You can come get a chocolate later. Ooh. Oh, you can have that too if you want. Yeah, so that sort of makes sense. The risk of exposed divided by the risk of those who weren't exposed. So 400 divided by 150. This basically says that you're 2.67 times more likely to be killed if you're involved in a cycling accident without wearing a helmet. All right, the next question was the proportion of deaths that can be attributed to not wearing a helmet in this study. Karen G. I really can't hear you, but I'm going to assume you're right again. That's spoilers. Yeah, so I hope you said 400 minus 150 divided by 400. So that means of the 400 deaths with no helmet, it is likely that 150 would have occurred anyway. So therefore, 5/8 of those who died not wearing a helmet died because they weren't wearing a helmet. Yeah? Yeah.
Why would it be able to cover number of deaths? That's supposed to different types of people.
Yep.
Deaths, exposed deaths.
That's fair. So what you're saying is the question's asking what's the population attributable fraction?
Yeah.
Fair enough. I agree. Yep, I wrote this really late. Sorry. But yeah, you could argue that. Good work. You get a chocolate. Oops. I'm just not going to throw them anymore, and I'll leave them up the front. You can collect them later. So yeah, what he was talking about was the population attributable fractions, which is this. Yeah, fuck me. All right. And the last one was the odds ratio. Does anyone want to offer up their answer? Okay, I'll offer up my answer. Did everyone get that? Is that straightforward? Hope so. Cool. So that's just a summary table. Won't go through it. Morbidity, not important. Study designs, they love this. So there are two types of study, well, three, but there's two here. So observational studies are basically like when we watch nature take its course without interfering, whereas experimental, we actually have a role to play. So the only experimental study design we talk about is RCT. So in an RCT, we allocate people to a group and say, you take that drug, etc. There's also analytical studies, which I'll talk about later. And that's just the hierarchy of evidence. Just have a general idea of that and how it works. So like meta-analyses are obviously the best, and like shit you see in the paper is the worst. So ecological studies, these compare large groups of people. So either different populations at the same time or the same population at different times. So that's like prevalence of HIV in China versus Australia, that's 2 different populations. Or the prevalence of burnout in Med1022 cohort in 1st year versus 4th year. That's the same population, different times. These are extremely prone to confounding factors and mainly used to highlight and identify areas of concern. So, for example, the low life expectancy of Indigenous Australians. We can't really say what's causing it just by seeing that there is a difference, but we're just highlighting that difference. Cross-sectional is when we look at a cross-section of a specific time. So a good example would be if I said, everyone in this room, raise your hand if you need glasses to see. And don't actually do it, I don't care. And then I said, all right, and how many of us have a Netflix subscription? Okay. And then I make up a table and an odds ratio and determine whether there is a strong correlation between Netflix and poor eyesight. Yeah, that's cross-sectional. So you're seeing who currently has this risk factor that you're investigating and then who currently has the disease or outcome. So it's all at one point of time. With a cohort study, it's different because you're finding people without the disease currently and noting their current exposures to any risk factors. And then you follow them along and see who develops the disease. So you can have prospective and retrospective cohort studies. So with prospective, you're recruiting individuals who are currently exposed to certain risk factors and then follow them forward to see if they develop the disease. Retrospective is when you use information from past records like medical records, hospital certificates, whatever, to determine whether they have been previously exposed, but then you still follow them forward and see if they develop the disease. Both of those involve people who currently don't have the disease. The only difference is when the risk occurred. So these can establish causation, but they are difficult and expensive. So imagine like a study that follows 10,000 people over 10 years. It's going to cost a lot of money to keep track of everyone, and people usually want to be paid to be included in studies. So like, yeah, that's just really expensive, really difficult and time consuming. Case control studies are essentially the opposite. So that's where you find people who currently have a disease and then ask them about their past risk factors to ascertain whether they were exposed to certain risk factors that you're investigating. So this is really good for rare disease. And the reason for that is, imagine a disease that affects like 1 in 1 million people in Australia. If you did a cohort study where nobody has the disease currently, because that's what a cohort study is, it would be extremely unlikely that any of them would go on to develop the disease anyway, right? So you would have wasted like 10 years, lots of money, etc. In a case control, you find those with the rare disease first and then go backwards to see what risk factors they were exposed to. Does that sort of make sense? You can't really establish causation, only correlation. An example of why you can't really establish causation would be like, if I said I had a really bad headache today, and now that I think about it, I had a really bad night's sleep 3 years ago, I can't say that that caused this. Okay, there are just so many confounding factors, so many different things that you have to take into account. So this can't establish causation. That's just highlighting how they're different. So yeah, they're essentially opposites. A lot of people get confused between retrospective cohort and case control because that's sort of where you go back in time thing. In case control, you start with the disease and then find out whether they have risk factors. In retrospective cohort studies, you're looking to see if they have risk factors from the past, but you're still following them forward, right? RCTs, gold standard. So this is where subjects are randomly allocated to groups that determine whether they will receive a certain exposure or not. Obviously, there are ethical implications of this, so you can't intentionally harm someone. So I can't say like half the cohort will have their right arm amputated and then lifespan will be compared to those who didn't have their arm amputated. You can still have confounders and errors, but usually in RCT, they're really strict, so they help to minimize these. And they're commonly used for drug trials. So systematic reviews are a type of analytical study, which I said I'd mentioned before. So that's when no new data is collected. You won't be conducting a clinical trial or anything like that. Instead, you're analyzing previous studies and critiquing them and seeing how reliable and valid they are. And a meta-analysis, it generates a meta-regression from lots and lots of different RCTs. So a meta-regression shows the overall average or result. You don't need to know how to read them or understand them even. Just know that it shows the overall result based on heaps of studies, okay? So an extremely simplified example would be, out of 1,000 studies, 999 said vaccines are safe, and 1 said that vaccines cause autism. Because there is an overall consensus that vaccines are safe, we can sort of conclude that they are, okay? That sort of makes sense? And you won't be tested on these probably. Interesting to know, I guess, if you want to. Weird again. Question 5. So 60 individuals above the age of 80 with osteoporosis were asked how much and how often they drank milk while they were 20 to 50 years old. Karen, pick someone. Case control? Yeah. Yes. Does everyone get why that's a case control? So you're finding people with the disease currently and then asking them about their previous risk factors. So 100 people were randomly selected and assessed to see if they currently had depression. They were also questioned on how often they currently practice mindfulness. What kind of study is that? Oh, is that a question? Yes. Good. I'm not going to throw that far. You can come get it later. What was your name? Okay, cool. So validity and reliability, just really quickly. Validity is the capacity of a test to measure what it is intended to measure. So there's internal and external. So internal is, are the results correct for the population you studied? So was the method of collecting data or recording results correct? So if you had 10 people in a study who averaged 1.7 meters in height, and your study found that the average was 1.6 meters, your data is incorrect or your results were recorded incorrectly. So then it's not internally valid. External is, can these results be generalized to the entire population? So the 10 people have an average height of 1.7 meters again. You conclude that this is the average height of the population. However, the true average height of the population is 1.8 meters, for example. So therefore, your results aren't able to be generalized across the whole population due to a sampling error or bias or something like that, which we'll go into later. Reliability is just, would you be getting the same results if you did this study over and over again? Any questions? Okay. Errors, they love errors. So I like to think of random errors as things caused by unpredictable changes. So if you took your own blood pressure 5 minutes apart, you could get 120 on 80 one time and then 110 on 75 another time. So that's just natural chance, okay? You may just, by chance, have picked the 5 people in a population who have a rare disease, making it seem much more prevalent across the nation than it really is. Does that make sense? With systematic errors, they refer to biases in your study. So instead of just by chance, all of your blood pressure measurements were high by 10 millimeters of mercury. You may be doing a study across 2 different labs where they do things differently. So that's sort of your systematic errors. So some examples of those are selection bias, when the population involved in the study is not representative of the entire population. There can be heaps of reasons for this. Some of them are volunteers. So volunteers may already have an interest in the topic that you're studying, or they just might be more health conscious in general. So you're going to have a cohort of people who really care about their health, and they're going to make it seem like they're a lot healthier than the rest of the population. The healthy workforce effect, you don't have to remember these, just understand why they happen. So people currently working are more likely to be healthy as sick people will be at home. So if a study is conducted at a workplace, the sample will be healthier than the general population. Loss of follow-up, so people who are getting healthier are less likely to come back for routine assessments, so the cohort seems unhealthier. To combat these biases, you try and increase your sample size, have clearly defined eligibility criteria, and try to maximize retention of people throughout the study, which is difficult, but yeah. Recall bias is just when people make errors talking about past experiences. So it's particularly present in case control studies. So for example, women who had premature babies were asked if they felt stressed during their pregnancy. And the mother thinks to herself, well, maybe I was stressed. That's why my baby was premature. And that's why I'm involved in this study. So she's like, yeah, I must have been stressed. So they were more likely than the controls, so women who had normal term babies, to report stress. Does that make sense? And interviewer bias is when the person conducting the study records results differently based on the group that the patient has been assigned to. So this is why we do double-blind tests in RCTs, so that the person recording the results doesn't actually know if the person in front of them is in the placebo or in the actual drug group. Biostats. So numerical data involves numbers, categorical involves categories. Discrete numerical data, so it only takes specific integer values. So you're essentially just counting. So if I said we were surveying how many siblings we all had in this room, we'd have people saying like 0, 1, 2, 3, 4, but you couldn't have like 2.75 sisters. Continuous numerical data is a measurement and more like a spectrum where you get a range of results and all of the results will lie somewhere within that range. So the easiest example is measuring height. So someone could be 171.94 centimeters, but not a specific integer, obviously. Nominal data is categorical, where the order doesn't matter. So imagine a survey that asked for your gender, country of birth, hair color. Okay, it doesn't matter what order those get placed in. In contrast, ordinal places some significance on the order of the categories. So you've probably received a survey that's like, how satisfied were you with this service? So very satisfied, somewhat satisfied, neutral, somewhat dissatisfied, or very dissatisfied. The categories mean something when compared against each other. Relating more to medicine, and ordinal could be like, what stage of cancer is this person in? So the order matters there, whereas nominal could be, what blood type are you? Dichotomous data is binary. You're either a yes or a no, instead of fitting into one of many categories. So this can be like, do they have cancer or do they not have cancer? Are they dead or alive? This one's pretty easy to understand. It's just important to remember that whatever way it is skewed is the way the tail faces. That's just a tip. Stats and hypothesis testing. So when I talk about categorical or continuous factors and outcomes, so categorical is like discrete. And so a categorical factor could be like sex, so male or female, whereas a categorical outcome could be, did the patient die or recover? And continuous is the opposite, it's the spectrum. So a t-test compares the mean of two groups. So a two-sample t-test compares separate groups, like measuring the height in males versus females, or the average life expectancy in Australia versus China. A paired t-test still compares the mean of two groups, but it's usually a before and after. So measuring the cholesterol levels of a group of patients who have recently been prescribed some statins. Okay. Chi-square tests or chi-squared tests or whatever, they involve categorical factors and categorical outcomes. So an example is, do you smoke? Yes or no. Do you have lung cancer? Yes or no. So it's kind of like the cross-section. And you can use it for odds ratios and relative risk calculations. All good? Correlation is pretty straightforward. So it shows you the relationship between two continuous variables. And a good example is just height and weight. Okay, so both types of regression tests have categorical and continuous factors. The difference is that linear regressions have continuous outcomes, while logistic regressions have categorical outcomes. So an example of a linear regression is the effect of height and gender on blood pressure, and logistic would be the effect of height and gender on a decision to undergo surgery for some procedure. Okay, does that make sense? Try not to get them mixed up. Any questions at all up to this point? Oh, we are cruising. Accuracy, how close you get to the true value of whatever you're measuring. So if you took someone's blood pressure and it was the same as their true blood pressure, that's accuracy, okay? Precision is how close together your results are when you repeat them. So if you took someone's blood pressure 10 times and it was very close together, regardless of whether it was close to the true result, that's precision. And those targets pretty much summarize that. Hypothesis testing is good fun. So I guess the way to think about this, or the best way to learn this, is to go through an example with you. So let's say that the null hypothesis, which suggests that there is no relationship between a factor and an outcome, is that there's no relationship between old age and dementia. And then the alternate hypothesis that says there is a relationship is that age is a risk factor for dementia. Okay. So in a hypothetical study where we got one person from each age from like 1 to 100, let's say 90% of those above the age of 60 had dementia. Then we did a lot of maths and we would calculate a p-value of 0.03. This means that there is a 3% chance that even though it looks like there's a strong association between age and dementia, we just got that result due to chance. Okay. Obviously 3% is ridiculous. And it's much more likely and logical to say that there is a relationship between the factor and outcome. Therefore, you reject the null hypothesis and conclude that there is a relationship between old age and dementia. Does everyone get that? Because that's pretty important. And I think I explained it really poorly. Yes? No? Thumbs up? Thumbs down? No one moved? Great. So hypothesis testing errors. So type 1 error is when the data says that there is a relationship between the factor and outcome when there isn't one. So you've incorrectly rejected the null hypothesis. Type 2 is when the data suggests that there is a relationship when there isn't. No, when there is no relationship when there is. So you've incorrectly accepted the null hypothesis. It's pretty straightforward. Standard error is just used for confidence intervals, and it's used to compensate for random errors or biases. So instead of giving us one value and saying that's the result, we give a range. And that's the confidence interval. So standard error isn't that important. We just use it to calculate the confidence intervals. Don't really know how to calculate them. Don't try and remember that. I was just using it. So confidence intervals are the important thing. So a 95% confidence interval will tell us that if we repeated the study many, many times with different people, 95% of the confidence intervals we calculate will include the true value of the population. Okay, so this allows us to account for standard errors. So generally, the smaller the confidence interval, the more statistically significant the result is. And that sort of makes sense. If the confidence interval is a range of odds ratios, then it is only statistically significant if it does not contain 1 within the confidence interval. Remembering that odds ratios measure the strength of association and that an odds ratio close to 1 is statistically insignificant. Therefore, if we have a confidence interval that contains 1 in it, then it's possible that the true odds ratio contains 1, is 1, and therefore it's insignificant. Does that make sense? Because I just fumbled. Okay. If both ends of the confidence interval are greater than 1, there is a positive association, and if both are below 1, then it's a negative association. Okay, so confidence intervals are better than p-values in determining statistical significance, as you can only see whether an association is due to chance or not with p-values, whereas with confidence intervals, you can see other things like accuracy and precision. This part's kind of bullshit. There isn't really much to explain. I'll just go through it really quickly. So definitions, pretty straightforward. You can look at that in your own time. So the clinical onset of disease occurs after incubation and the infectious period occurs after the latent period. So those two are related to each other. And these two sets of infection status can occur concurrently and overlap. So you can begin having symptoms before being infectious, or you can be infectious before you have symptoms. Any questions with that one? This is gross. Just have a general idea. Don't think you have to remember it. I don't think it came up in our exam or anything. I just like to say it. Diagnosis and screening, this stuff is important. So just some revision, primordial, primary, secondary, and tertiary prevention. Can anyone tell me what level of prevention screening is at? Yay, great. So diagnosis and screening. So diagnostic tests are conducted after identifying potential symptoms. So you've been coughing for 2 weeks, you see a GP, they give you a diagnosis, okay? Screening tests are conducted before the onset of any symptoms. So there are different types of screening tests. Opportunistic is when you're offered is offered when people are being examined for other reasons. So you go to the GP for a flu vaccine and they're like, can I just take your blood pressure while you're here to make sure everything's okay? That's opportunistic. Mass screening is when you screen the entire population without considering at-risk populations, and that's just wasteful, I guess. High-risk screening is better, so when you screen groups that have risk factors for certain diseases. So a good example is screening for like familial cancers that run in the family, or for black lung disease among coal miners. Multiphasic is when you conduct 2 or more tests at once instead of carrying out several tests for single diseases. It kind of confuses me, but I think an example is like a urine dipstick where you're measuring lots of different things at once in the one test. And this stuff is super important, can't stress enough, like definitely know how to calculate these. It's easy to mix up the equations. So sensitivity is how good the test is at picking up what it's intended to, so the true positives, okay? So of all the diseased individuals, how many tested positive? Specificity is how good the test is at excluding negatives, so the true negatives. Of all the healthy individuals, how many tested negative? The positive predictive value is of the people who tested positive, how many actually have the disease? And the negative is the opposite, so of the people who tested negative, how many are healthy? And a note there is specificity and sensitivity don't change based on prevalence, but PPV and NPV do. Okay, lead time bias and length time bias. So lead time bias is a screening bias that makes the screening process look better than it actually is. So it occurs specifically when early detection of a disease has no effect on the disease outcome, and this is due to ineffective treatment. So for an example, let's say I have a terminal illness and I'm going to die at the age of 30 with or without treatment. So if I presented with symptoms at the age of 25, it would seem like I lived with the disease for 5 years, right? However, if I got screened at the age of 20 and they found out I had the disease earlier, it would seem like I lived with the disease for 10 years. And that seems better, obviously. But the point is that despite nothing changing in my prognosis with or without treatment, the screening test looks more effective and better because it adds 5 superficial years to my life. Does that make sense? Oh my God, got some nods. Not to be confused with length time bias. So that's just confusing. Just remember that if you have a slow progressing disease, you're more likely to be screened because you have more chances to be screened because you'll live longer, right? So the idea is that screening tests are more likely to pick up slower progressing diseases that wouldn't have killed people for a long time anyway. So therefore, prognosis seems better than it actually is across the population. So if you look at the picture, the person at the top has the slowest progressing case. And say, for example, it was recommended that you get screened for this certain disease every 5 years. And it took 10 years for the disease to kill them. They're obviously going to get screened. And if you look at the 2 people below that top one, maybe for them it only took 3 to 4 years to kill them. So they didn't get screened, they didn't get included in the results. So the picture we get when we look at this is that 3 people got screened and 100% of them lived for a while. But in reality, 2 people died before they could have been screened. So yeah, does that sort of make sense? More nods? Great. So there's a question. Just be careful in the exam with these, because with our one, they swap the axes around. So don't just visually learn the equations like that square divided by that square or whatever. Actually know what you're dividing, like the variables you're including. All right, do we have answers? Anyone want to offer up specificity? Oh wait, I forgot, I can't hear you guys anyway. So specificity, so that's all the people who don't have breast cancer who got tested negative. So 350 divided by the total amount of people without breast cancer, and that's 7 on 10. Make sense? Okay, sensitivity. So of all the people with breast cancer, how many tested positive? So 550 divided by the total amount of people with breast cancer, and you get that. So positive predictive value. So that's of all the people who tested positive, how many of them actually have the disease? So that's 550 divided by all of the people who tested positive, and you get 11 on 14. And the negative predictive value, the opposite. So of all the people who tested negative, how many of them are actually negative? Any questions about that one? Have I confused people? Great. I had something to say. Fuck. All right, if I remember it, I'll come back to it. But that was real quick. This is shit joke of the day number 2. That was Epi in a nutshell. Good luck, guys. That's pretty much it for Epi. Don't stress out too much.
Oh, that's taking too much.
Looks like you were. But we had a you and everything. It was a secret. Yeah, she's got it. And then you just walked right past me. No, she's not coming. No, she's not
Oh my god, it's a really microphone.
You know, Ham's power. Ham is power.
Fuck out. So you can't have one.
We can.
Like religiously or like
That we've never had.
like comparatively?
I've never had. We never
They have no idea what's in this, so they're just like.
Well, you were. I mean, my mistake. You go.
Pretty good.
Vegetarian body. Okay.